I am Mary Cordova, one of the co-founders of Concierge Care Advisors. We help seniors find care for in-home care or a transition. I'm here with our Physician Advisory Board, Dr. Brian Ferris and Dr. Alex D. Moraes.
Thank you. It's great to be here.
Thank you for
Thanks
coming.
for asking
gentlemen.
us.
Thank you.
Whether it's a drug, whether it's a surgery, whether it's a service, whether it's a DME, the right thing for the right person with the right diagnosis at the right time in the right dose for the right duration. It's broadly applicable, right? And I think that not everybody should, let's say, have, as we were talking about the durable DME and how hard it can be, I wanted to say somewhat cheekily, unless you need the motorized scooter and watch late night TV, just
That's you, right?
The 1-800 number to easily get your motorized scooter. They handle all the paperwork.
They don't.
I know they don't, but that's the example of the sort of suck you in. And what I mean by that is, we know with aging and illness that the aging process, that part of your life, the course can be dramatically altered by injury and illness. And more often than not, by the demographic numbers, I think it's illness than injury. And you want to get them through that, but it's a decision point that they may never get it back. And by where I think DME could be a two-edged sword is that if it's not looked at properly, then they never make it back. And maybe that's the right thing. I don't know. Again, there's a very heterogeneous patient population in the setting of a very heterogeneous set of diseases. When you look at the top 10 list of why we are mortal, there's a lot of broad categories there, but how they impact somebody with or without diabetes and what complications from their diabetes or cancer, which type of cancer, and what that cancer is doing, and on and on and on, really kind of dictates what that conversation of how we use these tools and whether, this is the way it is or this is the way it is for now. And those are two different conversations, I think.
Yeah, I think you're absolutely right.
And again, I talk about my top 10 list. I know others in the online chat, video, blog, whatever space talk about the 4 horsemen. The things that broadly take us are our body systems fail. Brain is one of them. Cancer, but it's also dwarfed by cardiovascular, which is my space, and cognitive.
For me, it's cardiovascular disease because it is so broad in nature. Typically, we think we're healthy until we're older, and then we look at our cholesterols and say, "Oh, I'm healthy," or "I'm not." But that's just such a minute picture in your health. The other thing that we've done too is a disservice to women because we look at women and say, "Oh, you look great, you're healthy, your cholesterols are great, your HDL is 90, right?" But internally, you don't have the genetic makeup to protect your vessels. So in time, you're building plaque,
Right.
And that plaque leads to heart disease. It leads to kidney failure. It leads to dementia, and you're fine until one day
You're not.
Yeah, you forget the stove on, or you forget where your keys are. I had a patient who drove from Bellevue. She was going to go to Safeway and ended up at the Canadian border.
Oh, my gosh.
And she didn't realize it.
Right.
But I wish that I could rewind her life and go back to when she was 30, 40, 50, and look at her history and look at her family history and maybe do some of the specialty testings that we can do today to look for plaque and plaque buildup and say, here are the things that we can do from both a social perspective, and if those don't work, from a medical treatment perspective, to keep you, I tell people I can't make you live longer, but I can help you live healthier.
That quality of
and
life.
what I call it is straightening the curve. So, instead of your health declining and then you get ill and you're an invalid and then you pass, my goal is to keep you healthy and vertical and walking, and then one day you get sick rapidly and
Right.
pass, because we're all going to pass one day.
Compared to failure to thrive.
Flatten the curve is not the most popular
Right.
term these days.
Yeah.
But I think you're spot on it, because I think when we went through, we talked about the paradigm of quality of life versus quantity of life. And then other terms have come: ADLs, activities of daily living, functional status, and things like that, where now I think another term out there is lifespan versus health span. And Alex is totally right. When you look at that top 10 list,
Right.
and you really try to put it into broader categories, the big one is cardiovascular. And I think it's also representing and this is spending a little bit more time on the medical side than
That's okay.
than everything else. But to frame it into context, when we went through and you looked at your Introduction to Clinical Medicine book, there was a chapter, and in that chapter there was stuff on stroke, which is a blood vessel problem. And then in a different chapter, there was the heart thing. And then there was a few paragraphs in some other chapter about leg arteries. And then I somehow distinctly remember, and maybe it's my bias, that there was like a paragraph on the back page about aneurysm. And a ruptured abdominal aortic aneurysm in men has been in the top 10 list for mortality. So it's not a small number. Now it's way down comparative to a heart attack. But when you add it all together, stroke, heart, and you look at the arteries, so when the heart pumps, it pumps blood to your brain, your limbs, your organs. That's the arteries. You can feel your pulse, measure it with your watch. And you look at that as an organ that ages and develops this plaque, this narrowing. It's incredibly pervasive, and it's not escapable. You're gonna get it.
Right.
And we learned that back in the Vietnam War, when our lost soldiers were coming back and they're getting autopsies, and we were seeing aortic atherosclerosis in 18-year-olds.
Wow.
Now, they didn't die of a heart attack back then, but it set up this lifelong process that we've altered. We've altered it by changes in smoking. We don't nearly smoke as much as we used to, but we've traded it somewhat by the incidence of metabolic diseases, increase in weight, diabetes, etc., so on and so forth. But we've also got great tools, and we're learning better tools that includes lifestyle, not to pay any lip service to it, but also not just statins as medications, but now we're growing that suite of medicines, because they do have side effects. They're not for everybody. But we've got great options that, again, when the opening statements came of why I see upstream, I see the impact. I feel like I can reflect on my career when we didn't have it into when we started using it, and that impacts their ability to walk around without pain, their ability to not have chest pain, shortness of breath, as well as cognition. And Alex was saying on the cognitive side, now we may even have better testing.
Yeah, and you know,
And the diabetes as well.
I've never referred somebody to Brian and said, this person has no plaque, no issues, can you please fix them, right?
Right.
So when
Quite
he's
the opposite.
when he talks about illness and disease within vessels, he's actually, you know, at times opening up vessels and peeling plaque out. I've assisted in some surgeries before, and the reality is really, it's like the pipes in your home.
Right.
They build up to a point where you can't get water anymore. And that lack of water flow is what leads to little areas of your brain now dying because it doesn't have flow. And over time, you start losing cognition and develop dementia, right? And it's a little bit different than Alzheimer's dementia and Lewy body dementia. There, you can start classifying forms of dementia, but ultimately, all of these lead to the inability to carry on your activities of daily living, which in essence, you know, your family now has to care for you.
Right.
And it's hard to love somebody and care for them when they can't perform their own activities of daily living, whether it be walking, bathing, changing your undergarments, It's
Feeding yourself.
it's a
But
full-time task.
And I think your analogy is fantastic because it is kind of like the house and the plumbing in several different ways. One, that stuff on the inside is not homogeneous. It's actually very heterogeneous. There's soft stuff, hard stuff, which isn't really the point. But the analogy of the house is couplefold. One, it may plug up the little parts of the shower where the little tiny holes don't work, and it may be all the way up to the water main. It also may happen so slowly that you don't notice
Right.
that you're not taking a good shower, you're not getting the water pressure, you can't. That all has a human impact, as you just said, where the individual, the patient, or the family, they don't even see it happening
Right.
until all of a sudden, and that's called observer bias, and all of a sudden there's a sentinel event, some sort of shocking event where, oh my God, how did this all happen? It was fine last week.
Right.
When it really wasn't.
Exactly.
And
Just having a good day. That's how we.
yeah. And then something breaks and everybody's sort of shocked, and it's a reality check, if you will, to go, oh my gosh, how far down this path we went, and there's nothing wrong there, but I think it's a recognition of how far it can advance along in terms of a disease process, and the impact in the brain is the hardest because it's not easy to see. We can feel a pulse, we can check an EKG, but the brain and how complicated the brain is hard to measure.
Yeah, and you have to actually do imaging. That's the challenge, to get an MRI of the brain in somebody who doesn't have any cognitive issues or is beginning to have some challenges is extremely difficult, and it's denied over.
Well, and
and
even the clinical testing is very involved. There's not a lot of people that do it, and it's hard, and it takes time.
And it takes time, but by the time somebody brings a family member to me and says, I'm worried about mom or dad's cognitive changes, I don't need testing.
Yeah, they're in deep.
Right.
Yeah.
Right. But by then what we're doing is we're trying to salvage the little memory that's there, but we're behind the curve. There's not a whole lot you can do other than start to prepare for changes. It just takes time. You have to be aware. The other thing I see too is people come in and they're like, I'm healthy, right? I exercise and I eat well, but mom had a stroke at 62 or may have had a heart attack, and then there's an older brother or sister who have had heart disease or a heart attack.
Yes.
And then dad lived to 87, but dad died of a massive heart attack. So you have to look at family history because they're the canary in the coal mine that can guide you to the fact that while your cholesterols look great, internally, genetically, you might still be building plaque. And Brian will tell you this. He's probably seen people with beautiful cholesterols. They're stunning, right? But if he were to open up their vessels, which he probably has in the past, they're full of plaque.
Right.
And then the other thing you see is you see people with horrid cholesterols, right? But they're absolutely not plaque builders.
Right.
And they have longevity.
No rhyme or reason.
And it's interesting when you look back to their genes, and genetically they either have great family members or extremely lucky. I don't know.
It's a very it's very complicated, and it's not just a cholesterol level, which is not the right thing to test. It's a lipid panel, which may even be seeing the setting sun. It's all about what levers we can push, and we don't have. We got a lot of stuff, but we don't have. The metabolic pathways and systems are far more complicated than all the tools we have. And Alex is totally right. Is once it's symptomatic, it's pretty far along, whether it's in the brain or in the leg, and anything in between. And where I was going with this is that, again, after the length of my practice, and in the context of the clinical trials, that helps flatten that curve where it's not a steady decline in whether it's cognitive function or physical function. and therefore their independence. But these basic lifestyle choices of staying active physically, staying active, engaged mentally, I think is a cultural change, right? Because I think that many of us in this room grew up where retirement and getting older meant the classic fairy tale of sitting in the rocking chair with your loved one, holding hands, and enjoying the view and the sunset and what have you, when that's exactly wrong. And you can really change that curve not only on the physical side but the mental side. So one of Dr. Ferris's isms has been, aging isn't for sissies, number one, but number two, you have to train for it, and you can have a big impact, I think, hitting all those systems on a personal note that can make a difference. And I don't think I'm wrong on that one.
No, and the stuff you're talking about, I think 5 really important things are exercise, and that can be something as simple as walking, right? So if you are a couch potato and you now walk a block a day, to me that's
improvement.
That's a positive change, right? Eating within reason. And that's different for everybody.
Yes.
It may be that you have no plaque, no risk factors, no coronary calcification. You can probably eat whatever you want, right? So you're eating to your own personal health and genetic makeup. Socialization. If you look at socialization within communities, it's been proven that people live better with less disease when they live in
socialize.
They socialize,
Absolutely.
right? They meet with others. They maybe go dancing. They maybe just
They're not
go
isolated.
to a dinner party, right? They maybe go to a dinner party and eat.
Absolutely.
That's perfectly fine.
Right.
The other thing is knowing your genetic makeup, and then obviously seeing your doctor and having. I'm going to add a 6th in here, which is having an advocate not only when you get sick, but ideally you have those advocates aligned prior to getting sick.
Through that journey.
And everybody knows who they are, so they can call upon them when the time comes instead of calling
afterwards during the crisis.
Exactly.
Yeah.
Calling during the crisis, I can't do much. If you meet with me prior and then you have a crisis, I can really be your advocate and ideally get you the best outcomes.
Yeah, to nerd out on a little bit more, I actually stopped using the term exercise because I think that it comes with a high bar, a standard. There's a vision there. And so I try and get away from that and say, look, it's really important to stay active. And I break it down into a few ways. You want to move, and you can call that cardio if you want to, and whether that's a walk, which is fantastic, or you want to get more aggressive, fine, but a walk is great. That's number one. Number two, keeping up your strength, I think is good, and lots of other people talk about that. I've long felt that our muscle mass is kind of an engine, and so I like to use car engine analogies and say, the more muscle you have, the more cylinders you have. So who doesn't like a V8, sort of, so to speak? And so strength is one thing, and how someone does it doesn't matter.
Right.
Weight is still weight. And if you're, using dumbbells or whatnot, or you're just using, you're lifting plants in the garden, whatever, it still counts. And now we can measure it better than ever. And then the third is that kind of brain-body connection. And you can call it stability, neuro, whatever. And I tell people to go dancing, right? I mean, if you want to do yoga or Pilates or anything in between,
get moving.
You can also go square dancing. And it's going to be great. And it's going to be a lot of fun. And oh, by the way, it includes the social side.
Right, exactly.
So, and I think that these help. And I think that all these factors are important in terms of not only pre-needing concierge care advisors, but then part of the equation of what they need when it's time and what their options are when going through the process of what concierge care advisors can offer, the choices, what they can do, and those simple steps, I think, keeps it from getting really complicated in terms of, well, Dr. So-and-so said this about my nutrition and the nutritionist said that and the blah, blah, blah. And, I can get cognitive testing in 4 months. And if you boil it down to some of these simpler things, I think that it's easier for most patients and families to understand.
Yes.
And I think it helps get the needs, because it's the broad brushstrokes.
Right.
That's the low-hanging fruit, in my opinion.
My favorite test is the sit to stand test.
Oh, yeah.
And because sometimes people when they
You're not going to ask me to do that.
Well, I could ask you, but you won't do it.
And I'll fail, actually.
Yeah, so it's very simple, right? You're sitting. This chair's a little bit low because typically your legs should be horizontal, but I ask my patients. I say, show me how you get up from the chair.
Right.
Okay, so they'll put their hands on the chair and get up. Sometimes they'll rock a couple of times.
Right. Get that leverage.
I had a 87-year-old lady the other day. She just bounced straight up.
Yeah.
Am I worried about her falling? Absolutely not. But what it does is, in a simple test with a simple question, shows them their capabilities or lack of capabilities.
Right.
So then I know that if I can get them some physical therapy for strength and balance, next time they come back and we do the test, and now they can get up without using their hands,
with ease,
we're moving in the right direction.
Exactly.
Because
that's fantastic.
I don't have time to do a full functional assessment like the physical therapists do. So it's just a quick little simple test that anybody can do at home. And if you find that your loved ones, they ideally should be able to get up from a chair without the use of their hands, but if they require the use of their hands, they probably need some assistance with strength training. And if they can't get up, then they really need help.
Right, and that's been talked about a lot. I mean, a doc that spends a lot of time in this space and I think does really good work is Peter Attia, and he talks about the goal of the octogenarian, the centenarian Olympics, and one of the tests is being able to get up off the floor. That's one of the events.
Right.
And I had this exact conversation with my parents when I found out that grandma had broken her hip. And so I kind of hear about it after the fact, and I asked, how did she fall? And the answer is, we don't know. And they told me what they did, and clearly the doctors checked for stroke and heart attack and
head injury,
arrhythmia, and so on and so forth. And it was kind of, no pun intended, a goose egg. They just didn't find anything. And so then I asked the next question, which was, okay, so what are we going to do so this doesn't happen again? And I was met with complete silence. And I recognized at that point that we were entering a really tough space. And it was simply just verboten that we were going to have that conversation. And being a little bit of the surgeon, I tried to sort of press the issue, and it failed spectacularly.
Of course.
I mean, it went over like the Hindenburg, and it didn't help. It didn't help anybody. And just made everybody frustrated. And it's really, too bad that this simple test tells such a story as if only your eyes are wide open.
Right, and what you see.
And can be done anywhere.
And then you can say, okay, it's time for help.
Right, and this is why.
Right.
Yeah.
And I was hoping that this would sort of be the shake up, and it wasn't. And I think I think this is not a unique story.
No, it really isn't. This is a segue into all of our advisors do free home safety checks. And that's exactly what I asked them to do, is watch them transfer. Have them show you how are they preparing meals, what's in their refrigerator, what does medication management look like, are there throw rugs, tripping hazards, are there handrails in the shower. So sometimes we can be your eyes and ears in their own environment. As you stated, you have 15 minutes with them within your own four walls, and we're going into their home.
And again, that's to me where it's time to have this discussion, because the challenges we're going to face are going to transcend the medical system. There's no way the medical system can do it. And so there has to be a better awareness of how to see these things as warning signs.
Right.
Right. Not everybody has to be a meteorologist, but if you can see a change in the weather, you can say something, right? You can be a spotter, and that can make all the difference in the world. And whether it's then contacting you all, or they're already involved, or both, and getting them into the doctor if that opportunity is there. And unfortunately for many, there's not that, and that's even harder.
Absolutely, especially when we find out there's behaviors and there's been resistance to see a primary doctor.
Just send them to HR.
I would love to do that. But there's definitely behaviors at home, and they're non-medicated. We always know that. If they're, violent, urinating everywhere,
Right.
the first thing I ask is, do they have any medication, any psychotropics, anything going on that would help with
Depends
this?
on the state
Yes. Yep.
these days.
Whether the
What's
state...
legal or not.
Oh, correct. Yeah.
And typically by the time you get to that position, where we've failed is introducing services like hospice and palliative care.
Right.
Because that can
An
really
oversight.
help, because by then typically we've had dementia with weight loss, or we have a diagnosis of some form of metastatic cancer,
Right.
or we have end-stage respiratory disease requiring oxygen, or congestive heart failure requiring oxygen. And people don't understand that when you get to that phase, you probably can't do the sit test anymore.
Right.
But that's when the services are out there for you. Whether it be calling CCA and getting guidance, whether it be getting hospice on board and getting additional services. And what's beautiful about services like hospices is that there's no cost to patients, and there's no cost to patients or families. Right.
Wonderful.
Same thing with you guys. There's no cost to patients or family.
Another set of eyes and ears on their patients.
And for families, I think the best, and you'll probably reflect on this. So if I have a referral to Brian for vascular issues or to any other specialist, I always ask the family to write what I call a one-pager. And so basically it's a summary of what's been going on. And when you get to the visit, just hand it to the doctor and sit back. Let them read it.
Let them read.
Okay. They're going to ask pointed questions related to what is going on. Otherwise, they're going to spend 10 of those 15 minutes getting the same information that you've just given them in 1 minute.
Exactly.
And it makes your visit so fruitful. And you leave out of there with better guidance, better answers, a better care plan. Would you agree with that?
Yeah, except for they say he said he would send it.
Instead of hand delivering.
Right. No, it's totally true. I mean, if you set up the it's exactly right. If you set up the context of the referral and they know why, they get the gears turning. And again, it helps get those eyes wide open instead of wide shut.
Right.
And the benefit of the curse of the digitization of a health record and the electronic processes to get things done is that with a click, referral is made, and it's touch free, if you will. And so they may not know why. And part of that again goes back to it's almost like Charlie Brown. What do they hear?
Right.
There's going to be the key word, and then everything else is going to be cancer, cancer, or stroke, or insert whatever word you want that may be. And so their mind and emotions are going, and this is normal. This is 100% normal. And if there's a way to say, here's what you need to think about, and I'm going to send you to the specialist, then again, that's another one of those points, watersheds in their path where they have to start thinking, okay, it may be time for a change, or a change will come at some point, because it turns out the incidence is 100%. It's not a question of when. It's not a question of if. It's when.
It's when.
It's when.
Yeah.
It's when.
And that's when we're called. 98% of our people that we help are need driven, coming from the hospital.
Right.
Can't go back home, had a fall, had an incident, or they're going to go to a skilled nursing center for a few days, or what they heard 120 days if they broke their arm, which of course we know that that's a myth. That's a calendar year, but people will call us and say, Mom broke her wrist. She's going to be at the nursing home for 6 months. And it's like, well, probably not that long, but
Yeah.
so they just don't hear everything. Doctor, you also mentioned genetics, and I think that's huge. And I think as generations are getting more savvy, they can do something with those genetics. And I think when, maybe 40 years ago, we didn't do a lot with our genetics and knowing what our demise was, or if we were going to be susceptible to dementia or diabetes or all of those kind of things. And being that my husband has seen the Overlake cardiologist, his is genetics. It's definitely genetics. So now, of course, my boys, I'm like, go get tested. Your cholesterol is definitely 30% from your genetics.
Well, I think in a way, we didn't use that term. I think we always have used genetics because at least on the medical side, we take a family history.
Right.
And I think that the action on that family history, which is your genetics, is proportional to the tools that you can use. Now we are getting to the point where we have some pretty interesting tools in terms of how they work,
Right.
what their side effects are, and of course cost. That's where the testing is also, the technology for genetic testing has gotten very, very sophisticated. So is it that everybody should run out and get their genome tested, whether they're looking for rare diseases, whether they're looking for polygenic scores, is a different question. I think the question is, where are you in life to know, again, qualitatively, well, everybody in my family has an MI. The classic example is Jim Fix. And this is maybe a generational thing, but Jim Fix was a runner, and he wrote a book in the 70s called Running. And it was very poignant for me to use in my patient population because they're of that generation. And he talked about the development of longevity as a concept because nobody in his family that was male lived to be 50.
Longevity.
And he added 10 years because he ran.
Wow.
But that's all he did. He still smoked. There were no statins or anything like that. And he got 10 years and then he died. So he knew his genetics and he made an intervention. And I think there's lots of interventions that you can do that are maybe choice driven or environmental driven in terms of the choices you can make. And those should be even caged as you're influencing your genetics. Now we can nerd out on we can spend the rest of the evening talking about that. So I should probably stop there. But I don't think a DNA test of one form or another should be pushed on everybody. And even as it's gotten easier, and I've tried to have the conversation where even I thought it was a good idea, I'm shocked at how many people say no.
Oh.
I'm very specific with DNA testing. I don't do it at random because number one, it can introduce the concept of I was going to say genetic defect, but maybe that's wrong. A DNA abnormality that you perceive will influence you and never will. And never will.
Right.
Never ever will.
Gotcha.
Right. And that changes observer bias. It's called the Hawthorne effect.
Yeah.
Is what it is. It changes your behavior because you know it's being looked at or you know you have it and you don't know if it's going to be a problem. And that's ethically a disservice.
That's what I think. On my husband's side, we took care of his father, and he didn't know who we were. But we took care of him until the end of his journey. And with all this testing out, the sister-in-law is like, oh, I think I want to get tested. She's a worrywart anyways. So I'm like, oh, I don't think you should,
Right.
And I was wondering
well,
about
genetic testing in the phase of working with a geneticist is different to me than random genetic testing that you can get out there. And there's genetic testing that looks at true disease risk, and there's genetic testing that looks sort of at where you came from, your background, and that's completely different.
Right.
So when I do genetic testing, I always consult with a specialist. I had a case with Brian on somebody that had an incidental finding on a test, and he became hyper worried about the process, right? So we did very specific genetic testing to show that he didn't have that.
Oh,
so what
good.
we found wasn't really going to impact him long term.
Right.
Okay. So it took his angst away.
Yeah, gave him a peace of
instead of
mind.
now being before, if that genetic testing wasn't there, he would have been subject to repetitive CT scans because the insurance companies won't cover MRIs and you can't do an ultrasound. So now I'm inducing harm by radiating him repetitively
to
right?
ease
Right.
his
And so that
stress.
and that goes back to whether it's part of this episode or another podcast. I can do all this stuff to change the disease curve, but I've shortened their mortality because I gave them cancer.
Right.
And so these are very difficult questions that, again, go back to that simple curve of knowing how to do something, whether it's operate or how to test, but when to and then when not to.
That's how
Love
it's
that.
best used. It's used when to influence change in an individual or when to make them understand that they're not susceptible to that
Right.
disease to take their angst away. But just if we keep random, even body scans, that's a whole separate subject that we're going to end up, I think, harming more people. And there's numerous studies out there on test ordering within the medical community, and number one, the cost, and number two, the harm we really do to patients long term. So
Right.
let's keep trying to avoid that.
Yeah.
Love your philosophy on that, doctors. Thank you so much again for coming to the podcast.
You're
Thank
welcome.
you so
Thank
much.
Yeah, it was fun.